Welcome to Myopain Seminars, Eureka Seminars presentation on fascial manipulation, the Stecco method, exploring a total body approach. I'm Larry Steinbeck, and I'm here with Colleen Whiteford, and we're going to give you an overview, beginning today with a little bit of my story of how I got started in learning about fascial manipulation or with organizing fascial manipulation. But before we do, I just want to give a quick shout out to Andrew Hauser, who's with the sports medicine staff of the Los Angeles Dodgers. I appreciate you spreading the word, and we appreciate all you folks that signed up. If you're ever in Atlanta, those that are listening, those that might be part of sporting team, feel free to contact me. Let's get together and talk about fascial manipulation. 12 years ago, I was taking a dry needling class through fascial manipulation or through Myopain Seminars to put another tool into my toolbox. I'd been a physical therapist almost 20 years at that time, and hopefully, like many of you, were always looking for a way. I was looking for a way to be more efficient, to get better outcomes with the folks that I'm dealing with, whether it's through exercise or doing a manual treatment. And while I was taking the class, looking through some references, I stumbled on this article by Carlos Stecco, where you can see the title being the expansions of the pectoral girdle muscles and their onto the brachial fascia and at the morphological aspects and spatial distribution. Well, it piqued my interest. So I read the article, discussed it with Jan, and we began to read more and more about fascial manipulation, which led to more articles that we researched, not these necessarily in particular, and ultimately it got me to Luigi Stecco's book on fascial manipulation, that the English translation done by Julie Day, who one of my mentors in fascial manipulation, got me to the point where I had these tools in my toolbox, but Luigi was showing me that maybe in addition to all the tools, I needed to have a way to organize the tools. And fascial manipulation gave me a means of being able to take these tools and teach me how, where, and when I should be using these tools. So I like this quote that Luigi has: the importance of treating the whole gesture rather than one single muscle, rather than focusing, rather than being myopic on one specific component. We need to have a wider view and be able to look at relationships of movement, of muscle, and as I learned with deep fascia. So Luigi taught me how to organize what I was doing treatment-wise, and hence my fascial manipulation toolbox that you'll see, whether for some folks, whether they use a needle, whether they use a cup. In my case, combination of needles, combination of knuckles, combination of elbows to treat through the fascial manipulation method. An example of that is an article that came out just last year. And you can see it talks about a global approach for plantar fasciitis with extracorporeal shockwave treatment. And what they did basically in this study was that they looked at areas to treat based on, as it says, fascial manipulations principles by Stecco, that describes 3 different planes of the fascial system that's used in treatment, in this case, looking at the limbs and pelvis. What they did was they chose strategic points that are mapped out through fascial manipulation that we'll get to as this session progresses. But you see points in red that relate to each other they treated on the first session, points in green that they used in the second session, and points in blue that they used in the third session. So treating the plantar fasciitis, they didn't stick to just the plantar fascia. They looked at those components that had some sort of functional relationship that's described through this model. And here is their conclusion. This is the application of the shockwave therapy at not just the plantar fascia, but doing it in these points of what they described as these impaired myofascial points that we'll describe in just a bit, throughout the leg, through the pelvis, was effective at restoring the sliding properties or the equilibrium in the myofascial system of the entire lower limb that allowed them to return the correct function of the plantar fascia without treating the plantar fascia itself, which many times can be quite painful and quite inflamed. In their opinion, this is something that will help be more effective in the long run than just treating the plantar fascia itself. So we'll look at these functional relationships between the fascia, between the muscle, between joints that move. We see areas that fascial manipulation can be used. In this case, with a specific stroke patient and a rotator cuff tear, we see this article by Pintucci where he demonstrates that using the fascial manipulation method, we get an effective return of active range of motion through the involved limb. Study I was involved in, we looked at fascial manipulation for people with a multitude of low back or low back related diagnoses, and using this functional approach, this model of fascial manipulation to treat at a wide area in a very specific, almost algorithmic way to resolve specific musculoskeletal conditions. As an example, we had this patient that came into our clinic, and you can see that here this 3-5 represents weakness in the plantar flexors. These asterisks in the middle represent specific areas of limitation in fascial mobility, similar to the dots that we saw in the previous study. And what was unique, you saw that she had this 30-degree straight leg raise. We treated specific points along the way. This happened to be in the lateral buttocks, this in the lateral thigh, this in the lateral shin, here in the medial shin, over the medial gastroc, and also in the foot. After treating those points, we have an increase in straight leg raise to 50 degrees, and we have an increase in plantar flexion strength to 4-5. This video shows, maybe this video will show. Let's go again. All right, a little bit slow in coming. Okay, so this video will show here this weakness per se with the plantar flexors on the right, where you see she can't maintain this heel rise as she steps, that it just drops down to the floor. So we have this 3-5 muscle strength. Treating the points that we talked about just a second ago, we see when she returns a week later, we have this increase in strength where she can maintain this plantar flexion quite a bit better in her right ankle. Following the model, we see her a third time or in a third week, and we see the ability of being able to have even increased control in the ankle plantar flexors. So even though this person came with a diagnosis of lumbar radiculopathy, by treating the whole lower limb, by treating that in relationship to what was in the trunk, we see this widespread gain as far as motor control, ultimately with a 75-degree straight leg raise after 3 visits in our clinic. Now I'm going to turn it over to Colleen, and she's going to go over an overview of the fascial manipulation method.
So hi everyone, this is great. We have such a great turnout with this, and thanks Larry. So I'm a physical therapist. I'm in Virginia and I'm in private practice. And next slide, Larry. Yeah, this is like the husband with the remote. I can't control the slides. I don't like this, but anyway, we'll go with next. So I became familiarized with fascia manipulation about 2009. Like Larry, I was taking dry needling training with myopain seminars, and I'd never heard of fascia manipulation or Steccos. And it first came up then, and I was a little bit curious about it, so I ended up taking an introductory course. That's where I met Larry. He was teaching the course, and my life has honestly never been the same. I was just amazed to listen to Larry talk about the biochemicals that are thought to be causing the problems for a fascial densification, and they were exactly the same ones as are thought to be causing problems for myofascial trigger points. And that's why I picked this slide and listed these here, because Larry was reading over this list and explaining this is what we think is going on when there's problems in the fascial network. And it totally astounded me because the science was the same. But then the more I learn about it, if you think about it, there's so much interplay between the fascia and the muscle that you really can't separate the science. So it makes sense when you appreciate the relationship between those two different but very much related structures. So I decided, I came back from that class, I started applying the little bit I knew about the method, and I was really surprised at the results that I was getting, and it made me want to have more training. So I pursued that. I've since been to Italy a couple times and taken a lot of courses, worked with Larry, and now I'm certified and I'm an instructor. I use fascia manipulation every day with practically every patient on practically every visit. It's really changed how I practice, and just the whole, it's become a very essential component of my practice model. Slide, Larry. So I put this in because I at one point just wanted to think about all the different places in the body that I can treat at this point. It's really expanded how I practice and how I use it as a total body approach, but it enables all of us in our practice to treat just an amazing array of diagnoses. If you look at all the things that are listed on here, it's quite remarkable. I mean, I'm an orthopedic physical therapist specialist. That's what the OCS stands for. And yet I have a growing population of a women's health caseload that's almost as many as my orthopedic patients. And I'm not a formally trained women's health physical therapist, but I get very good results using the fascia manipulation model. It's been remarkable to see how that has just evolved from knowing this method. So as I see it, fascia manipulation shares many fundamentals that a lot of other approaches share, and yet there's some key differences in how you apply these fundamentals. And that's what I want to take a look at now. So slide, Larry. All right, so for instance, with a history, we all know how to take a history, and a history is not unique to the fascia manipulation model. My experience with history taking was I would spend a lot of time talking with a patient, and especially if they had a really involved and long history, I would be recording a lot of information about past problems, maybe even current problems, but that wasn't what they were coming to me for. I would be recording about surgeries, illnesses, maybe traumas, fractures, but I didn't really know how to integrate that into why they were seeing me now. It didn't really take me anywhere with it. I would just basically record it and look for red flags and yellow flags, but then not really integrate it into their current treatment program. But in the FM model, history is very important, and we're very interested especially in that old stuff and other problems that the person has had or may be experiencing. There's a saying in FM that is old as gold, and basically what that means is that the cause of a current complaint may really be stemming from an old problem that was never fully resolved. Even if the old problem isn't causing any more apparent pain or dysfunction, it still may be related to the current complaint that's bringing somebody into our offices, especially if that current complaint is insidious or idiopathic in nature. Oftentimes there's always a reason for what goes on in the body, and sometimes the reason for that current complaint really lies in uncovering that old history in the past complaint. Next slide. So another element that's not unique to FM that we all utilize is inspection or observation. And it's not unique to FM, but much like when I used to get the history, I would also do inspection on people and make note of all these things that I might see, like tibial varus or foot asymmetries, deformities, the toenails that are pictured there. I don't know if you can see it very well, unhealthy or removed, enlargement in the joints, or just asymmetries even as people lie on the table where the shoulders are internally rotated, one foot's rotated out more so than the other, or even skin disorders as I have pictured down in the left-hand corner. All of these things I would note, but I really didn't know what to do with them, kind of like those old things from the history. But with the what's unique about the fascia manipulation model with inspection, I had a funnel or a filter for determining what those things were telling me, and maybe even what part of the body might be crying out in distress and needing some attention that really wasn't an area of complaint or didn't seem to be exactly related to what the person was coming into me for. It gives me a method of interpreting these observations on people. Next slide. So movement assessment is another, you went too far. There you go. Movement assessment's another aspect that's not unique to fascia manipulation. And we all use movement, or most of us do, to guide our treatment, our evaluation, and tell us whether or not what we're doing is working on a person. In FM, fascia manipulation, we use movement testing that isn't all that different from a lot of other systems. So what I've pictured here is just some very basic, triplanar movements. One of the things down in the right-hand corner, that guy was a bow hunter, and I was simulating with a gesture him trying to pull back on his bow because he had trouble in his shoulder when he was doing that. So using movements, using gestures in a triplanar manner or even in a diagonal manner, that's not unique to the FM method. But what is different, again, is that funnel and that filter that helps me narrow down the information. Because we all know there are so many movement tests you can do on people. You can move so many things in so many directions, and then even getting further into special tests and provocation tests. You can spend a lot of time on this stuff, and at the end of it, it can get overwhelming and confusing trying to decide how does this tell you where you should be going on this person. But with the FM method, I'm very precise with the movement tests I pick. I have a plan and a model based on the history with where I want to move, and it narrows it down so that I'm only going to do movements that will absolutely help me know what's next, where I need to be going in treatment for this person. Next slide. So palpation is another fundamental that's not unique to the FM model. But what is unique in this model is having a method for approaching it, and this particular method. In the FM model, we have guidelines for where we should palpate based on the history, but then also some guidelines with maps of, you'll see these in a little bit, of how do we determine which part of the foot might be important and which part may not give us as much information. So it gives me an organized method based on the history and the movement, and then it tells me exactly where I should be palpating. Next slide. So overall, this method just guides me and funnels me down to where do I need to treat this person to get the best result possible. Once I've done that, I've got a lot of options with treatment tools. Larry's already mentioned that. I have several pictured up here. I will say that for me, my number one tool is my elbow. And my husband says my elbow is pretty targeted and sharp. My husband works with me and is a physical therapist also. And actually that's him pictured down there using his knuckle on a gastrocnemius. But the manual element in FM is really critical and important and very helpful, and I think the most effective. At the same time, there's other tools that you can use that might be appropriate according to the person, according to the body part, and according to the problem. So I'll use percussion on people, I'll use vibration on people, I use dry needling. It depends on what I'm trying to accomplish and what the problem is. I also use cupping, as Larry has mentioned. I don't have a picture of that on here. Different tools according to whatever the need is and whatever suits that person. Next slide. So what I've done here is I wanted to bring in a little bit of the clinic into this explanation to try to show you what the FM model looks like in the clinic. So this is my patient, Lisa, and her beautiful family. She's a 29-year-old referred to me from the gynecologist for postpartum problems about 5 months now. And this is a person I probably wouldn't have seen if I didn't know how to work with the women's health population in my orthopedic practice. But she had several complaints that I might elaborate more on in our upcoming webinar in June. We have a pelvic health one coming up in June, and I may go into a little bit more of what I worked with her on in that. But for the moment, I'm just going to focus on the orthopedic kind of problems that she had. So let's go to the next slide. But don't play it yet, Larry. So she was doing well. A lot of her women's health kind of complaints were coming along nicely. But it was a visit a little bit into maybe the 4th or 5th visit, I don't remember, where she was telling me more about hip symptoms that she had. And she didn't talk about her hips in the beginning. She didn't tell me that that was a problem. And so I had no idea. But this visit then I decided, okay, let's focus on the hips. So the first thing I wanted to do, I went back and went to my basics. I already had her history. I'd already done inspection, but now I wanted to repeat some movement tests. So I did triplanar movement testing on her with the hips. And when we play the video, I hope this plays okay, but I want you to listen for the snapping that's in her left hip. I could hear it across the room. It's a little harder to pick up on the phone, but hopefully you can hear it. I don't think the volume's on. Shoot. That's the one that's not snapping so loud. Do you feel anything in the hip with that? Just a little bit. Okay. And that's better than it was. So let's do the left side now. Okay. And I don't have to ask if you can hear that one. So I'm going to get closer just in case it didn't get picked up and we can't pick up. Go ahead and do it again. We're going to see if we can hear it. Yeah, so that's her hip clicking. It's not the floor, the furniture, or anything else. All right. So now what we're going to do is go to treatment. Okay, so I couldn't hear it very well on this, but I could hear it when I played it earlier. So sorry, and maybe you all could hear it better. I didn't hear it on this video, but anyway, you probably all have heard that, and I've heard it called the snapping psoas. It was a clunk, very, very loud, and I could hear it across the room. The right hip, I forgot to mention, we'd worked on the right hip the prior visit and had gotten a nice change with that. But then when she came back for this visit that I recorded, the left hip hadn't responded the same. So I was trying to figure out, well, why would that be? Because I would have thought it would work for both visits. But then she related in this visit, she told me of a problem with her left knee that she forgot to tell me about, or I can't remember if she forgot or she just didn't think it was important. Either way, it was a problem with her left knee that dated back to high school. So it's kind of an illustration of this old as gold thing that I didn't know that was a problem for her, and she didn't tell me about it. So the next thing I did was I revised my treatment plan a little bit, knowing that there was probably something lower down in her leg that was making that left hip snap when the right one had responded so well to the prior visit. So next slide. So what I did next, I said I went to treatment, but what I did was I went to palpation first. So I put her on the table, and this is what I chose to palpate. I wanted to palpate her hip because that's where this snapping psoas is, so to speak. And I wanted to palpate around her knee because that's where the old complaint was. So what I've put up here on this slide, this is just 2 segments that show from the fascial manipulation model my guideline for where I palpated on her. There's a lot of triangles and circles on there, but basically this is my guideline for what I want to see. Is there a problem in any of these particular points? What I found on her was a little bit in the left hip, which was snapping, and nothing in the left knee. So I knew I needed to expand my search. So next slide, I went up a little bit and I went down a little bit, and I moved proximal from the hip and I went up into the pelvis. And what I found there was an area that had lost its slide that my palpation could perceive. The slide was lost in the tissue layers on the right side in a point called retropelvis in the sagittal plane. And I also found on the left talus or calf that she had lost slide on the left in the left calf in the same tissue line, retro. So I've had that correlation, so I decided that was good enough, and I went ahead and proceeded with treating. So next slide. And that's what I'm showing here. So the first thing I did was prep the retropelvic point, which is the iliolumbar ligament, and I used the hypervolt so it doesn't hurt so bad and take so long. And then I finished with my manual to bring in some shear force, but also to complete the treatment and also palpate and assess the change in the tissue. Then what I also did, next slide, was I went down and I did that left leg. And this is the medial head of the medial aspect of the lateral head of the gastroc. They're both in the same tissue line. So it made sense to me that I would have a correlation and maybe something that would catch her hip in the middle. Next slide. And so then, unfortunately, this isn't going to have the same impact because you can't hear the change in the sound, so I'm sorry for that. I could have used a microphone maybe to turn up the sound. But this was her after I treated just those 2 points. Let's go ahead and do the right hip. Let's do the left. That was good. I didn't hear anything. Okay, let's do them again. Do them both again, just for some movement. Oh, wow. Is there any clicking at all? It's just like my right one, so it's like a mild. Very tiny, very mild. Okay, so let's finish out some other spots and see what else we can change. Okay, next slide. So sorry if you couldn't hear that, but it was there. I wouldn't have put it on here if it wasn't there. All right, so my last point with repeating this slide is just that then she was so pleased with her results that she had her husband come in, and I've started him just yesterday, and I can tell you that they gave me permission. So it's kind of cool the way you can, having the women's health aspect can draw in even more people for you outside the women's health realm. Next slide. So what I want to do here now is I'm going to briefly give you a very elementary overview of how I explain this to patients. Larry's going to follow after this with more detailed anatomy and physiology, but I like for a patient to understand what I'm doing before I do it with them. So I'm talking sort of like you guys are patients, and this is what I would tell you in a treatment room. So I show this picture. This is my husband cleaning a deer in the kitchen. This is not a cadaver, it's a deer tenderloin. And he's lifting up on the filmy stuff, the thin fascia. And fascia, everybody knows what fascia is, sort of. It's that white filmy stuff that wraps around meat. And it doesn't just wrap around meat, it wraps around every organ in your body, every blood vessel, nerve. It's all over, head to toe, right to left, front to back. It's continuous and it's everywhere. And what you see him lifting up on is the thinner layer. And then if you look underneath, it looks thicker and just like milkier or whiter. And that's because that's the deep fascia, and it's thicker and tougher, and it's harder to pull away from the meat. Next slide. And what we see here then is sort of a schematic of that same thing. He was lifting up on that upper white layer, and that thicker white layer is down on top of the muscle, and that's the deep fascia layer. And it's really not just one layer, next slide, but it's actually 2 to 3 layers of tissue that are collagen fiber bundles that are laid down parallel to each other, and they all face the same direction by layer, but they are spaced apart, and the next layer is going to have the collagen fiber bundles oriented a different way. They have to have space, and they have to have slide between them in order to function properly. Next slide. And what gives them that space and that slide is hyaluronan. Most people have heard of this. It's in injections like that might go in a knee joint. It's also in some beauty products. Hyaluronan is the lubricant for our connective tissues in the body, and it's found all over. Next slide. So what we want is what's pictured under A. We want the space, and we want the slide between those layers, and it's thought to rule movement. But what happens sometimes in B is that instead of having space and slide, it gets compressed and stuck together or adhered. Next slide. And that's thought to happen because of tissue overload. Tissues get overloaded by, next slide, very easily with things that we do all the time. So from trauma, injury, from repetitive movements, immobilization, we are encountering any or all combinations of these all our lives every day, and it changes how the tissues move. Next slide. And in people who have lower back or chronic neck pain, research shows that there's changes in these fascial layers and how they actually set themselves up and become modified. So let's say this is a patient who has lower back pain. Next slide. I'm going to show them this picture and correlate to, now this is where I want to palpate on you and see, have you lost slide in some places that it's really important not to lose slide? That would be these points all along here, and careful research and dissections and studies have shown that these points matter. And we're going to look at your back because you have back pain. That's what's bringing you in here. Next slide. But we're also going to look at your foot, and I want to look for the same thing in your foot, and that's because you had that fracture 20 years ago in your foot, but you may still be missing some slide, and now it's playing into part of your back problem. Next slide. And what we want to see is, can we draw a correlation? Is there a relationship by this fascia? Because remember, it's continuous. It's running from head to toe, right to left, and maybe it's running from your back and down to your foot, and that's the relationship between the problem. We'll get a better response if we bring all of this history and movement problems into this. Next slide. So that's the end of my patient explanation. And usually then I'll go to the table and we'll work with the person, something like what you saw me illustrate with Lisa. So just kind of summing up, I like this slide because I think it shows nicely what this method does. You start out with a history of a person, and they've got problems everywhere. They give you all these things that you have to be focused on, and you're trying to funnel it down. And we do that next with movement. Movement narrows it down a little more precisely to where do we really need to be working on this person. Then we narrow it down further with palpation. Again, refining finally until we get to where are we going to treat this person to get the best result, as opposed to being overwhelmed with so much information. All right, next slide, and back to Larry for a little bit deeper explanation of some of what I've covered.
Thanks, Colleen. That was good. Now we're going to go through, as Colleen just mentioned, the anatomy and physiology, some of the work that the Steccos have done, as well as some others a little bit deeper as far as how we put all these things together. And even though we're watching this on GoToWebinar, we're going to zoom through this rather quickly. Here you see 2 photos that were taken from Carla Stecco's book on the functional atlas of the human fascial system. If you don't have it, I recommend it. It's not geared toward any specific methodology or school of thought, but is really the best text out there about teaching how the human fascial system looks in a very functional way. So I encourage you to see this. If we focus on the deep fascia, we see on this photo on the left that things that we were taught in school, the deep fascia being this glove or encompasses the muscles as a whole and helps to hold them in place. And what we'll learn is that this aponeurotic fascia, or this fascia between here and the thigh, the fascia lata, and the fascia over the leg, the crural fascia, that it does indeed encompass the whole leg and does keep muscle intact. But we'll learn that it's interesting, as Colleen had mentioned, that it's this multi-layered structure. And there's a specific reason for that, or appears to be specific reasons for that, as well as this deep fascia. In certain areas, it's free to glide over the muscle, but in certain instances, it's firmly attached to the muscle. So it has this role when the muscle contracts that it has some specific tension that it applies on the deep fascia. Here we see out of Luigi Stecco's book, Fascial Manipulation, Practical Part, the first level. We're looking again at the fascia lata, and this gross view, we can see those at least 2 layers of parallel collagen fibers that take place in the fascia lata. What we can't see is the 3rd layer with a more oblique approach, but we have this multiple layer layout of the deep fascia. Here, Stecco demonstrates that when this organization is present, that if we take one specific layer, we know if we pull longitudinally along the collagen fibers, collagen resists a lot of tension. It takes a high load in order to break the collagen fibers. However, if we go transversely across those parallel collagen fibers, it's very easy to separate, or easier to separate than if it was longitudinally. So there's a specific reason, a specific reasoning on why the deep fascia may be organized in this manner and be able to hold loads through multiple directions. Here we see a specific slide showing those multiple layers, that we have collagen fibers in parallel, separated by a layer of loose connective tissue. And this is what the key, this loose connective tissue we will see in between the collagen layers of the deep fascia. We'll see the loose connective tissue layer between muscle fibers themselves. We'll see a loose connective tissue layer between muscles as a whole. This is where the hyaluronin sits and allows for this slider glide. We'll learn about the alteration in hyaluronin, or this viscoelastic structure that is present that creates this this impairment. What's unique, or what we see with the deep fascia, as I said, that the aponeurotic fascia is free to glide, free to slide, but in some instances it's specifically attached to the deep fascia. Here you can see the aponeurotic fascia of the lower limb. So again, fascia lata, crural fascia, that if we look at semitendinosus muscle has a unique attachment to the crural fascia. So when semitendinosus, a muscle in the thigh, contracts, it has influence over crural fascia. We'll see why this is important if it advances. Oh, come on. There we go. Other than looking at crural fascia, here we see in the upper limb that the antebrachial fascia On the posterior side, we have the extensors, in this case, extensor carpi ulnaris, where part of the extensor carpi ulnaris takes its origin off of the deep fascia. Part of the extensor carpi ulnaris and the deep fascia are separate, so we have free slide or glide. Here we have unique tensioning that takes place. Opposite anterior surface, we see flexor carpi ulnaris, where the muscle fibers have a unique attachment to the deep fascia. So as the muscle contracts, it has a specific pattern that it lays on the deep fascia. Other than muscle myotendinous insertion on the deep fascia, we also have these myofascial expansions. In this case, it's lacertus fibrosus, so the anterior aspect of the elbow. We can see the biceps tendon that is being held by the forceps, and coming off the biceps tendon, we see this myofascial expansion that takes place. So we have tendon, and then we have the antebrachial fascia. So there's this unique pattern from tension from biceps tendon that leads into the antebrachial fascia. The same pattern happens at every articulation. We see it from the trunk into the upper limb. We see it from the trunk into the lower limb. Muscle contraction to some sort of insertion through a biarticular muscle into the deep fascia. What's neat about the deep fascia is that Stecco and others have observed that the deep fascia is really innervated. We have free nerve endings here, brachial fascia, crural fascia. We have capsulated, so Ruffini corpuscles. We have Pacini corpuscles, and this same framework is found throughout the body. Certain areas may have a predominance of free nerve endings. Others may have a predominance of encapsulated structures of Pacini and Ruffini. We see a higher proportion over the retinacula than we do in mid-substance. We see a higher proportion likely in the intermuscular septa. We won't get into why today, but just know that that does occur. Also in the deep fascia that Stecco has observed is that the muscle spindle that we see here, so you see the annulus-spiral rings, we see the interfusal muscle fiber. As Baldessera says, the capsule of the muscle spindle is either attached to the paramecium or to the fascial septa, or fine connective tissue threads, or in the intramuscular spaces. So instead of the muscle spindle being attached directly to the extrafusal muscle fiber, it sits within the deep fascia. So we have to have mobility of the deep fascia in order for contraction of the intrafusal muscle fibers to be efficient, and for activation through 1A afferents of the extrafusal muscle fibers. This will be important as we look. So if we go back to the original article that I read, the expansions of the pectoral girdle muscles onto the brachial fascia, the morphological aspects and spatial distribution, or what led to reading this is that during various movements of the arm, these expansions, so what we saw where these muscles have this direct attachment onto the deep fascia in a very unique pattern. So these expansions stretch selected portions of the brachial fascia in this case, with possible activation of specific patterns of fascial proprioceptors. We know that the deep fascia is innervated with mechanoreceptors, so the Pacini and the Ruffini corpuscles, as well as free nerve endings, which can act as mechanoreceptors. Because of that, when movement takes place, there's a specific stretching of those patterns, and it says that a different pattern of receptors are activated depending on the degree of joint movement. So based on position, that we have a unique set of receptors that are being stimulated. And as they have in quotes here, we say receptors embedded in the fascia could have this proprioceptive role. So we say fascia is rich in proprioceptive nerve endings. Because of that, each movement can activate this specific pattern of receptors. And because of that, the deep fascia could have a role in proprioception. So the father of motor control, Nikolai Bernstein, he stated that the brain can't handle movement, all the movements as a whole. It can't regulate everything, that it needs a discrete lower level element to help modify, to help with motor control. And based on the deep fascia being innervated by these mechanoreceptors, because of the deep fascia and its relationship to muscle insertion, either through these myotendinous insertions or these myofascial expansions, that these things can get together can fit that role of being this lower level discrete element to help modify or help add to motor control as a whole. This article that came out a few years back, anatomical and functional relation between gluteus maximus and the fascia lata. We see here gluteus maximus with these multiple intermuscular septa. So it provides this unique pattern of stimulation from gluteus maximus into the fascia lata. What's unique about this study is they point out how here vastus lateralis has a unique set of attachment to the fascia lata, how biceps femoris has unique attachment to fascia lata, how vastus medialis has unique attachment to the fascia lata. So all these muscles are providing tension and interaction with each other. We just don't see vastus lateralis working by itself. We just don't see biceps femoris working by itself. We don't see vastus medialis working by itself. And then if we look at that in relationship to a hip muscle, they are all working with each other, all communicating through these mechanoreceptors within the deep fascia, as well as this direct interaction of tensioning the deep fascia with their function. So because of that, within specific plane of movement that Colleen had mentioned, we see this interaction between agonist and antagonist. We can see what happens on one side of the limb versus what happens on the opposite side of the limb through the intermuscular septa. We know the muscle spindle sits within the deep fascia. The muscle spindle is coordinating or activating extrafusal muscle fiber activity. So because of this mechanical link, we have this function of tension between each other. So we have this reciprocal really activation to help control limb movement. And we also have this neurological reflex through the muscle spindles to help coordinate movements as a whole. Because we have this relationship between what happens through fascia lata and through crural fascia, sticking with the lower limb, we have monoarticular and we have biarticular muscles that we have the ability to have tension, as we saw with semitendinosus, taking insertion onto the crural fascia. The same thing holds true with sartorius, gracilis. All the muscles coming from the thigh have attachment through the distally into the crural fascia, and also proximally toward the trunk. Because of this interrelationship, not only do we have activation between agonist and antagonist, we also have influence of what takes place throughout the limb, or what Luigi talks about, a sequence of motion based on a specific pattern of activation of the muscles. And here's an example of treating that. This is a 17-year-old quadriceps strain, plays softball 3 weeks out, and you can see the limitation in movement. We know there's this relationship between agonist and antagonist. Because of the pain that was still present in the quadriceps, we don't have to treat that. They have a history of old hamstring strain. If we find limitation in movement and we treat that, we can have impact on the agonist movement or the quadriceps. And we see the result that takes place with improved movement without even treating the quadriceps as a whole. So there's a tensional relationship, and if that relationship is present, we can do very well. In this case, it's a week later, we're adding passive stretch the person can now tolerate, and we go through and continue to check overall mobility. So it's a neat little relationship that takes place. Now, how does this happen? We know that this is interplay between the deep fascia as a whole, but muscles sit within paramecium. And generally, when we look at an anatomical drawing, and like in this case, the paramecium, they're all drawn the same thicknesses. Luigi talks about how, in reality, the compartments, the intermuscular septa, vary in their thickness. And what we see is actually groupings of muscles that sit in a much thicker setting, or a compartment as a whole, that are involved with movement in a specific direction, or motor units that are activated for a specific function. So movements that move us forward are sitting in a specific compartment. Movements that move us backwards are sitting within a specific compartment. Movements that move us laterally or medially, in this case, sit in a specific compartment. So there's this highly organized relationship of the muscle to the deep fascia. Even with rotation, they observe it's not really a compartment per se, but with external rotation, muscles that influence external rotation tend to sit on the posterior aspect of the intramuscular septa, while those involved in internal rotation are involved in the anterior aspect of the intramuscular septa. So there's this neat little relationship that sits within the deep fascia to muscles involved in movement. With each movement we see, there's a monoarticular, biarticular muscle, which I said that sit within each of these compartments that have influence. Each of these compartments that have influence, in this case, is plantar flexion, or what we call retrotalo, that there's a group of motor units that are involved in performing this movement that are associated with this specific compartment. Motor units involved in a specific movement are spread throughout the muscle. So when a muscle contracts, motor units aren't adjacent to each other, but they're spread throughout the muscle. Because of this, there's unique patterns of tension that occur on the deep fascia. And Luigi talks about how these vectors of tension from the motor units that fire vary within a specific movement that's taking place. But physically, because of the vectors that are created, there is always a resultant of forces. And those forces converge on a specific spot, in this case on the epimysium. And that point where these things converge, where this tension converges on the deep fascia, Luigi has termed a center of coordination. The center of coordination, as it says, is where vectors formed by the intrafusal fibers, in this case of the vastus lateralis, involve straightening the knee. Now, the picture on the left relates to plantar flexion, or raising onto our toes. So we have this coordinated effort from motor units that fire converge on a specific spot. Because of this unique point, we can be very targeted with our treatment. That the deep fascia is ubiquitous, it's everywhere. So we don't have to look initially, we don't have to look for many different regions to treat. We can be very focused and be very time conscious of working on a specific spot. Luigi, I like it because he relates the center of coordination to that of a charioteer, that he has the reins to the horses, and the charioteer has to be able to organize the horses to move in one specific direction. As long as the loose connective tissue is fluid, as long as the viscoelastic nature, as long as the viscosity is normal, we have normal slide and glide, he can organize his horses like we can organize our muscles. Well, what happens when we are in a position where we don't feel the slide or glide? What do we think is actually happening? What is the dysfunction? Well, hyaluronin is a high molecular weight molecule, and they've observed that the molecules themselves can become aggregated or entangled upon themselves. One aspect of hyaluronin is that it binds water. When it becomes aggregated on itself, when it becomes entangled, it loses that property. It doesn't have as many binding sites. So without the water, the viscosity changes, and we have this alteration in slide or glide. What they have observed is that the more rigid a tissue becomes is because of a significant decrease in the viscosity. And this paper by Cowman explains why this happens and deals with this aspect of the normal slide or glide. Luigi hypothesizes, because there's this alteration in slide or glide, and because we have these mechanoreceptors within the deep fascia, that the threshold for stimulation has changed. So where we normally have this anticipated slide or glide and normal physiologic change in or stimulation of the mechanoreceptors, when the viscosity changes, or what we use the term densification occurs, so there's this alteration in the viscosity, changes the density, it increases the likelihood that those mechanoreceptors will fire, and the brain interprets that as some sort of dysfunction and gives it a label. May give it a label as pain, may give it a label as stiffness, may give it a label as tightness. that when people come in and they give you these different definitions, we believe it's because of this. And this is what it looks like. We talked about how the deep fascia has this multi-layered aspect to it with a loose connective tissue in between. This is in the proximal thigh or gluteus max area that we can see this nice contraction, and we see the deep fascia sliding and gliding, versus where we see this alteration here of the deep fascia, where we see this increase in space between the fascia layers, where the binding of water is not as concise. And with the muscle contraction, we see this limitation in the slide or glide of the deep fascia. So what do? We need to get this deep fascia moving. And how do we do it? We do it with compression. We do it with shearing. That we want to change the density of the tissue. We want to change the viscosity of it. And fortunately, it appears that hyaluronan is highly susceptible to this compression and shear, as we see here by a mathematical model produced by Roman and Chaudhry, that through vertical vibration, through back and forth of this tangential translation that we do with our treatments, we can begin to change that aggregation and restore the normal viscosity, or restore the normal content of the loose connective tissue. The hyaluron itself can be susceptible to temperature change. We think with our manipulation that we're able to instill this as well to help, as it says here, disaggregate the densifications or the deep tissue. So now it's time to talk about just a couple of cases.
Hey, Larry. Larry,
yes.
Jan we should have told people that they can send their questions in. We forgot to do that. So you can type your question in and we can answer it either as we go along privately, or else we'll address them at the end as a group as we talk about questions.
Okay. So I guess we can do that. So this was its total knee, and we'll just do it real quick. So the total knee arthroplasty. This total knee that had been going through, was being treated by another physical therapist. It was early on in my FM days, and I'm like, hey, let's try this. We don't need to continually mobilize the joint. We don't have to keep trying to put pressure on her to increase her range of motion. 6 weeks out. So let's look at the fascial manipulation method. Let's look at that point that we showed with the center of coordination for anti-genu. So we decided we'll just treat center coordination for anti-genu. We didn't mobilize the joint, and we changed the whole makeup of how this person moves. And initially they couldn't keep their heel on the table to do a heel slide. They don't have a sense of how they're moving. And just with treating one center of coordination, we go from, actually I don't even remember what the range of motion measurements were, but it's gonna come up, that we're gonna see from 92 degrees of flexion on her own actively to 104 degrees range of motion, just treating one center of coordination. Then we have to say, okay, let's treat the limb as a whole. So she has just a little bit of a delayed gait. This is after providing treatment to everything. She has this sense of being because the leg is treated as a whole, and without mobilizing the joint, without forcing range of motion, you see that we get this increased active range of motion over a week and a half to 118 degrees. So it's kind of cool to see this interaction play between what the muscle does, what the deep fascia does, this relationship to the joint, different than maybe how you've been practicing to this point. So now with resources, Colleen says it's time to take a stretch if you want. I'm gonna turn it back to her, and she's gonna go through the next set of slides.
Okay.
Maybe.
Thanks, Larry. That was good. All right, so let's see. Next, down to the book slide.
Are you there?
Yeah, can you not hear me?
Okay, maybe not. So these are the main texts that we used for our presentation. The fascial manipulation practical part, the first level, excellent text is what we use for our courses. If you consider taking one of our courses, it'd be good to read through the beginning, although this is what we hand out during the material for the course itself. This is my favorite book. that Luigi has put out 4 years ago, the Atlas of Physiology of the Muscular Fascia. I think it's the best that he's done as far as describing in detail what's taking place with his model. And then I had mentioned Carla's book, The Functional Atlas of the Human Fascial System, just does an outstanding job, but not does a great thing with describing the human fascia. Sorry for stuttering there, but I'm seeing these text messages and it's throwing me off loop. Hopefully you guys can still hear me. And then finally, this book from Julianne Day, Fascial Manipulation, Stecco Method, The Practitioner's Perspective. This was a group of instructors for fascial manipulation that used case reports to show how fascial manipulation is utilized. Colleen has a chapter in here, as well as myself. It's a great overall perspective of fascial manipulation. So I'm not sure, we're having a little bit of technical problem, and I'm not sure why Colleen.
Can you hear me?
I don't know if her mic is on.
It is.
But hopefully you can still hear me. So I can't get her to do that. Colleen, unmute your microphone if you haven't.
I did, Larry.
At this point.
I did. It's unmuted. Unmuted.
Okay, I guess Colleen's having some technical difficulties, although a friend says that she is on, so I just can't hear her for some reason. Okay, maybe now I can. Okay, my bad. Hey, man. End of the day.
Hi. I've been shouting at you.
Yeah. Okay.
There you go.
Okay. So could they see everything else, you think, or what?
Sure.
Sorry. Okay. So anyway, here's some articles about recent ones regarding fascial manipulation. This one that just came out in JSPT this past year is a great article about the intra-operator reliability of motor and palpatory evaluation and fascial manipulation. I'd say if you pick one to read, that's the one to read, because it gives good reason and why we can have this great inter-rater relationship of picking these points and determining what might be dysfunctional and what is not. So I'll let you continue, Colleen.
Okay. Thank you. That was great. So you can hear me, right?
Yeah.
All right. So there are more webinars and lots of things MyoPain is doing throughout this COVID crisis, trying to just keep us in touch and keep us on our toes and educated and making good use of our downtime. So one of the things that MyoPain has put together is live chats with the MyoPain needling instructor. So next slide. And there's all of this is available on the MyoPain website. This is what we're watching tonight. So we've already done the craft one that was last week. Tonight's the fascial manipulation one. Next week is the equine dry needling, and you can see the rest of these. If you register, even if you can't make it at the appointed time when it's going live, the webinar is happening, you'll still be sent a link that you can pick up later and watch it, the recording of the webinar. So there's lots of good stuff covering all the other things that MyoPain does in addition to dry needling. So there's lots of things with fascia and some exercise stuff with a playground approach that will be coming up in May. In June, as I mentioned earlier, we're doing a pelvic series. So that would be fantastic for people who even think they might want to consider that the pelvis is part of the body, even if you're not a men or women's health therapist. So next. Sure, what's next? Okay, and this is the chat with the MyoPain needling instructors. So this is a nice new addition to what MyoPain is offering. So you can see the times. You just register to be part of it, and it's actually an active real-time exchange with all the different great needling instructors that MyoPain has on staff. And you can see them here, and if one date works, or if you prefer a different instructor, then you can just choose that and register for that. Next. And also, because this webinar was free of charge, and instead of asking for any kind of fee for it, what MyoPain is doing is reaching out and asking for donations that would go to Share Our Strength. So this is a program for just reaching kids to make sure that they have food, in light of a lot of the school programs that are closed now were the main source of food for kids. So in many areas, it's really been rough on families. So if you go to the website, you can see more about how you can make that kind of a donation in lieu of any kind of charge for the seminar. And I think next, and that's our second last one. Yep. So we appreciate everybody being here, and I'm sorry that we didn't mention earlier that you can write your questions down and send them to us, and we're going to answer questions now, and we'll stay as long as we can and need to, and we'll go over all the questions and try to address what we see coming in. And you can always email us. If the very first slide had our email address on there for Larry and for I, or if you missed that for some reason, you can get it through MyoPain. And this is a great closing. This is my dog Grace, our dog Grace. She's a lab and she's being safe. So we welcome your questions. I see one.
I will admit my mistake. They were sending so many text messages and all those dings, I hit the mute. So I think all the things that say they could hear you, I guess I didn't want to hear you, so I had you on. That was my fault. But here's a question. I thought this was good. Right. How are the Steccos rationalizing how the neuroscience people believe in central mediation of pain? You can't disregard it, but at the same time, you can't disregard what's happening in the periphery. And there was an editorial in Pain Journal beginning of last year, and just the one quote that I love about that editorial is that the periphery still has lessons to teach. So the pendulum swings from one side to the other. We keep that pendulum in the middle, and we do a pretty good job. So it's not disregarded.
So here's another question. How do you integrate fascia manipulation in the treatment paradigm with dry needling and joint manipulation? From my perspective, it's dependent on the situation and the patient. For instance, I work in the state of Virginia. We can see direct access patients, but I can't needle without a prescription. And the prescription has to very specifically say dry needling on it. So even sometimes when a patient comes with a prescription, if it doesn't say that on it, I still don't have the option of needling. So I can be very restrictive and a lot of delays if I'm waiting to do needling. So FM has been a great adjunct to that. Also, I see it as sometimes the FM will give me a better perspective on where I might need to needle someone. For instance, the girl with the hip that you couldn't hear her snapping, I don't think, but it was there. The FM model that I applied on her might have led me to needle her calf. And that would have been a reasonable approach for the lateral gastroc because she had a major restriction there, a fascial densification. I chose to address it with the manual techniques and the percussion. But in another instance, I could have needled it. As far as joint manipulation is concerned, I don't use as much joint manipulation as I used to because I find, like Larry was commenting about the total knee example that he gave, that oftentimes once I free up maybe a restriction above the joint and below the joint, it changes the joint mechanics so nicely that I don't really need to use a joint manipulation or mobilization. It doesn't mean that it's not appropriate, and I'm sure there are instances where it might be the best, but for the most part, I find that I get very good results by using these other methods more often.
That's a good answer. Here's a question. How do the Steccos work relate to Tom Meyer's anatomy trains? Very similar. I think Luigi would say very similar, but developed autonomously for myself personally. Before I learned about the Steccos, I had read anatomy trains, and for me, working as a physical therapist, I related more to fascial manipulation and Steccos work because it's more algorithmic, it's more motor related, this motor control and functional relationships between these specific points that I didn't necessarily get out of anatomy trains, but they both speak to very similar aspects of it. Colleen, maybe you can answer this. Does muscle atrophy make a difference with treatment? Example, cancer patients with cachexia.
Does muscle atrophy make a difference with treatment? Oh, so would we use the fascial manipulation method on a muscle that's atrophied, I guess is how
I think
how
so.
I'm taking the question. I guess it would depend on why it's atrophied. Like I think maybe I didn't notice in Larry's example of the woman walking who had the weak plantar flexors, she might have had some atrophy. I've seen some situations where even a reflex was changed in a muscle or tendon by addressing the system around it and freeing the muscle spindle and the Golgi tendon organ to work properly. So I think the potential's there for changing muscle atrophy, but it depends on why it's there. If it's there, from some neurophysiology that's permanently irreversible, then I don't think it's reasonable to expect that it's going to change that. But I think it can have an impact when it's really a deficit that's more related to the periphery.
Okay. Another question is, how long do you treat each Stecco point in the treatment line? One study has been done, and what we teach is that we try and decrease what the person senses subjectively, 60% or so, 50% done in this study, along with what the practitioner feels as normal slide or glide within the tissue. And what they showed that in order for that patient to feel having the pain or 50% decrease in pain plus normal slide or glide with the practitioner, it averaged 3 minutes and 24 seconds roughly, but they can be a bit shorter and it can be a bit longer. It varies. The key is being able to sense those changes and having that relationship of what the patient senses.
Larry, I can't see, for some reason, maybe it's because I'm not a presenter or whatever, I can't see questions, so I'm just counting on you to.
Okay, well, here's one for you.
Great.
It says you mentioned trigger points, but I guess this question is for either or both of you, but I'll leave it to you. Do you treat the fascial CC and CF points and trigger points, or stick just to FM? Do you think trigger points need to be addressed if causing changes in the fascia? If treating both, is there one you typically address or treat first?
I'm trying to process the question. I first apply the fascia manipulation model. So my tendency is to palpate according to that model. But if I find something that doesn't seem to line up precisely with a point as I know it, with whether it's a center of coordination or a center of fusion, as Larry explained how they're arrived at, I'm not going to totally ignore that point. But what I might do is explore around it and see, is that place tender or feeling like it's more facilitated because it's coming from something somewhere else. For instance, today I worked with a young boy who had some headache issues, and he's been needled in a sternocleidomastoid, but I still felt his sternocleidomastoid was facilitated on the one side where the headaches are. But I actually was working much broader on him, and I worked down. I know this may be hard for some of you to believe for a headache, but I worked in his pelvis, and I worked in his ankle. And when I say in his pelvis, I mean he was on his stomach, and I was working on points in the posterior aspect of his pelvis, and it referred up to his head. So in that kind of instance, I think that's why the needling to his sternocleidomastoid didn't help him, because the therapist who was working with him wasn't looking broadly enough and taking into account his older lower back problems. But I've needled upper trap trigger points or fascial densification so often, I find they're often in the same places anyway. There's a lot of similarity in. That was actually one of the things that struck me about this method, was that I found myself needling in a lot of the same points often in different individuals. And it kind of begs the question of why is this so recurrent in people in such a similar place? Maybe not exactly the same place, but similar places.
I'll add this, that just because the loose connective tissue layer is in the deep fascia is continuous, so it's all over the deep fascia. We know that muscle is it covers a lot of ground, that a trigger point within the muscle can be anywhere. A change or alteration in the loose connective tissue can be anywhere. But when the trigger point or the densification are at the CC, that's what gets treated first before I would even consider looking for or treating a trigger point in another part of the muscle or a densification in any other part of the limb. That in my experience in learning this, if we work on those first, many of these other areas will adapt. Another question is, what are common FM patterns you see in the overhead athlete? That don't know if I can answer that. Specific patterns we haven't seen. It depends on continuity. We're working with some folks, or at least I am personally questioning to see if there are these patterns. In my practice, I don't see enough of them to say something definitively.
Well, I'll add and say, I think you really have to think about the whole torso when you're talking about anybody with a shoulder problem. And I'm thinking more, when I talk about an overhead athlete, I'm thinking of a lot of shoulder stuff. The torso is critical because the scapula sit on it and articulate with each other, and even the other shoulder is critical when you're talking about, you know, a right shoulder problem may have an impact by treatment on the other side of the body or the other shoulder too. So a global approach is really going to probably resolve things more completely for people. And I think it's sometimes what's missing when we keep having recurrent problems with people. So for shoulders and especially overhead athletes, we're working a lot of torso.
Okay. Let's see. How do you choose? Well, it says, how do you choose which direction to strum each Stecco point? And then one was, how do you find a CC? Do you want to answer that?
Yeah. So remember that one slide I showed when I talked about collagen fibers being laid down parallel to each other by layer. Can't see my hand as well, but the next layer they might be laid down differently. And there is some direction to the restriction that you might find, or the densification. And maybe it's because of that layer is more restricted with the fibers that run that way versus this one. So as we're examining these points, we're doing it in a direction of an asterisk. It's not just circular, but it's moving specifically like along the points of a star and trying to determine, is one direction more restricted than another? Is another direction more painful than another? They might not correlate, but they might. But then going with whatever direction seems to be the most restricted. And then also that you may have, you know, if you're working up here, you know, the anatomy may stop you. You can only move so far because the mandible is stopping you. So whatever the direction will be according to what you feel, but also what the anatomy will allow. And I forget what the other part of the question was. Or was there?
Me too, because I moved on. Okay, here's two parts, so maybe you can answer this one too. What sort of pressure levels are typically used with the manual therapy, and are the treatments painful or non-painful?
So the pressure has to be deep enough to reach the target tissue. So if you think back to that layered picture with the schematic of the layers and the fascia, we're going all the way through the hypodermis and getting down to the deep fascia that sits on top of the muscle. So you have to use enough pressure to make that happen. You have to consider if somebody's got a problem above that, like in the hypodermis, then for me, that's where I might check it out more by pinching instead, and I might choose to cup, because I don't have a lot of good results with trying to go past something that's painful to get to something deeper that might be painful. So the depth is according to whatever your target tissue is going to be. And if it's to be the deep fascia, then you want to use enough pressure to get down there. I don't know if anybody's got a measured amount of how much that is. Maybe some of those studies have that. I just know it by feel, and I go by feel. I can feel the densification and if I'm not pressing hard enough, then I know I'm not going to be at my target tissue. At the same time, if the person can't tolerate the pressure, then maybe what you need to do is use another tool first. Maybe they would do better with needling, because it can be painful, but everybody's different. Everybody perceives pain differently. I have people lying on the table and they make absolutely no sound when I'm treating them, and I ask for confirmation that this is uncomfortable, isn't it? Because that's what's typical. And some people say, yes, it's very uncomfortable, but they're very, very casual and don't let on much. And other people are squirming all over the place. So it's the individual's response and perception of the pain that makes it so different. But in that case, then that's where you modify what you're doing and how you're doing it according to the person that you're working with. Some people can handle multiple treatment points. Other people, you treat 2, and then that's enough for that person for the day. Everybody's different, and even on different days, what people can tolerate is possibly going to be different according to a lot of other variables that factor into pain and its perception.
Okay. I guess maybe one last question. This says, any insight you can shed on how correcting an old pattern could negatively affect an athlete's performance? Example, sports which favor one side and the power of movement is anchored in the fascial abnormality or lack of slide. For me, if you're seeing a person for the first time, we take into account just what Colleen had started her aspect of the presentation with, the person's personal history or personal musculoskeletal history. And we have to address that first, that any of those past events that took place, from fractures, surgeries, repeated injuries, impact mobility, can have an impact on this loose connective tissue of the deep fascia. Those things have to be addressed, but addressed in an organized manner. Once they're addressed in this organized manner, then we can look at specific movements that may have limitations, whether it's related to the loose connective tissue aspect, which is very quick to change, or is it a change in actual collagen or fibrous makeup that needs to be addressed. So any final comments, Colleen?
No, if I'm remembering the question right, I think sometimes when you're changing a tissue system that runs all over the body, you have to be open to the possibility that you may alter what their complaint was. And I'm not sure if that's an element of what was being asked there. I have made some people worse with an old problem that I almost brought it back to the surface, by treating their newer complaint. But I think it just illustrates the need to, as Larry was saying, look at the whole history and determine how these other old problems that maybe were silent or the person thought were resolved could very well be a factor in their current complaint. And sometimes too, when I remember to, I'll caution people that, this may change things, and, our goal is to make you better, but quite frankly, sometimes making somebody worse at least gives you a guideline of, this is where I need to go next, or this is how we need to complete this treatment program for you.
Okay, I'd like to thank Jan and MyoPain for letting us do this. This was good. I hope it was something that was helpful to folks, and maybe we'll see you down the road at one of the courses that gets reorganized after we get past this stage that we're in with the virus.
And if your question didn't get answered, you can email them all to Larry.
Really? And I was serious at the beginning. Like, if anybody's coming through Atlanta, email me. Let's get together and talk. I'd love to talk about it. Like to learn what you're doing. Yeah.
Yeah, we're happy to help with questions. If you didn't get your question answered, we'd love to talk with you further, whether it's by phone or if you can email it to us. So thanks everybody for being here. Really enjoyed it.
Bye-bye.